Hi, everyone. I am a third-year medical student here at UAB. I am applying dermatology, so surprise, I'm going to take you through a derm case today. This was actually a really interesting case that happened here at UAB, focused on Lambda light chain plasmacytoma, presenting with this paraneoplastic leukocytoclastic vasculitis in the context of septic shock. A lot of words there. So as an introduction, leukocytoclastic vasculitis is a small vessel vasculitis characterized by immune complex deposition, often presenting with this palpable purpura and petechiae. While LCV is commonly associated with systemic conditions such as infections and autoimmune diseases, it can be triggered less commonly by hematologic malignancies, such as in our case. The association between plasma cell disorders and LCV emphasizes the importance of thorough evaluations in patients presenting with vasculitis, especially those with underlying immunologic conditions. So in this case, we present a 60-year-old man with a history of systemic lupus with cutaneous features and monoclonal gammopathy of undetermined significance, who presented to the UAB emergency department kind of with this cough, chest pain, shortness of breath, and new onset non-blanching petechiae involving the lateral chest wall, flanks, upper and lower extremities. So if you take a look on the screen, you can kind of see the images, a little blurry here, of how this individual presented, and these images were taken on admission, and it was this like slightly palpable petechiae. I do think it's important to note that this patient does have, this history of systemic lupus with cutaneous features, but he was managed on belimumab, hydroxychloroquine, and that he had previously experienced some photosensitive rashes with the belimumab infusions, but he did describe this rash as like very distinctly different in appearance and in distribution. So we will now take a further look at this case in depth. So this patient was admitted to the medical intensive care unit, or the MICU here at UAB, and the dermatology inpatient service was consulted. We went ahead and did a punch biopsy of the left forearm, which did confirm this leukocytoclastic vasculitis. If you take a look at the screen, this is actually the path slide of our punch biopsy, and you can kind of see this like perivascular neutrophilic infiltrate and some little slight fibrinoid necrosis of the affected small vessels. So we figured out this individual had this vasculitis, and we were kind of looking for these underlying causes. We went ahead and did actually a full body CT, and we saw these mesenteric and paraspinal nodules. So we went ahead and did a CT guide biopsies of these lesions, and it kind of brought us to our conclusion. It demonstrated this Lambda light chain restricted plasmacytoma. We had some labs, and we had elevated IgG at 6,000. For reference, a normal IgG is 60 to 1,600, so pretty elevated there. And then our IgA was at 2,000. Normal labs there is 70 to 400. We questioned this individual a little bit more, and he ended up kind of confessing that he had lost 70 pounds in the past 6 months in night sweats. So kind of drew us to our conclusion further. His clinical course was very interesting because it was complicated by the development of septic shock, and we will take a look at that on the next slide in the discussion. When he was diagnosed with a septic shock, he was immediately started on vancomycin, and he ended up, having a recovery. He ended up being discharged from the hospital. He was in the hospital for about 2 weeks, and he followed up at our outpatient dermatology clinic here at UAB. His petechiae had kind of like coalesced into these larger violaceous patches. We put him on a triamcinolone ointment, really just for itching as needed. And he ended up getting a stem cell transplant, chemo, and he made a meaningful recovery. So this is kind of a success case for us. Now we'll take a closer look at discussion. So plasmacytomas are localized tumors of monoclonal plasma cells, and they can lead to alterations in immunoglobulin production and immune system function. And the relationship between these plasmacytomas and LCV really involves these mechanisms of abnormal plasma cell proliferation. Our patient's case was, very unique because we had this plasma cell disorder, immune dysregulation, and septic shock kind of contributed to this domino effect and really a heightened inflammatory environment. Our case was also unique because this patient was a part of a larger ICU trial here at UAB. It was like an NIH sepsis trial with Dr. Gagar. And so we had all this immunophenotyping from our basic science lab here that we really took a further look into. So if you look up here at table 1, blood was collected and centrifuged to isolate platelet platelet poor plasma, and we kind of looked at these markers under flow cytometry. So neutrophil and B and T cell markers were analyzed, and the neutrophil count was increased, and there were alterations in T and B cell populations, just really emphasizing the systemic immune disruption. And then if you take a look further down at table 2 here, we did the same thing. We spun our blood, and then we used ELISA to take a closer look. And you can see that the haptoglobin was elevated and there's altered hemopexin, really just indicating that there's multiple pathways of endothelial damage here contributing to our vasculitis and the development of LCV. I think it's also really important to note in this case that there are some documented cases of these paraneoplastic cutaneous manifestations, but none were indicated a plasmacytoma. We kind of did like a big lit search on this, and there were 3 cases of LCV presenting with the MGUS, but none had progressed to a plasmacytoma, kind of making our case unique here. And then if we take a look at the conclusion, there's really 3 take-home points that kind of myself and our team came up with. First, LCV may serve as the initial presenting sign of an underlying hematologic malignancy. I was listening to the sarcoid case, and it kind of reminded me of ours as well, of like, this may not be on the forefront of your differential, but if someone does come in with a rash, especially with like a history, in our case of the MGUS, keep a malignancy in the back of your brain. Second, concurrent systemic conditions can modify the disease course. Again, how we had this development of septic shock really just signified the immune dysregulation and really added complexity to our case. And then third, the definitive treatment of the underlying malignancy may be necessary for the resolution of the cutaneous manifestations. Again, we saw this patient follow up in dermatology clinic, and his petechiae had kind of like coalesced into larger patches, but we really didn't see the cutaneous manifestations resolve until he went through the stem cell transplant and the chemo. And again, he recovered. So thank you all. I'm happy to take any questions. Yes, it's interesting. So we did collect blood and urine, and there was no growth to date after 4 days of any organism. So we classified him in septic shock based of like the SIRS criteria. I don't know if you're familiar with this. So he had a lactic above 4, his whites were elevated, and he was in 2 pressor shock. So yes, we think that this was contributed by the LCV and the plasmacytoma. Yes. Yes, I think that's definitely an interesting point, and that's why we kind of took like a deeper dive into his medications. I definitely think lupus could have been a contributing factor just to a heightened inflammatory response, but I do not think it was like the underlying cause of progression of the MGUS to the plasmacytoma. Thank you, guys.
Please support our mission to improve quality of patient care through education. Join us, follow us, and share this content with family and friends.